This isn't. Okay. So here we go. This is us. You can see Drew's name. He unfortunately is not going to pass this course because he decided he's moving to Washington for a short period of time, not working with us yet. He knows this. All right, quick announcements. Please turn on your videos. I think Drew, you know, I'm anticipating more people as well, but the more nervous we can make him with faces staring at him, the better. But it's still better than staring at black screens. If there's more than one person in your room, please let us know. CME thing, you'll get the login thing at the end. Y'all know how that works now. Coming up, a couple weeks on the Tuesday Echo, we're going to talk about how we do some community integration and child protection and all the things. And that Echo is almost over. And then upcoming next week, you'll have to listen to Kurt talk again. All of the meds on alcohol use disorder, whether they are on label or off label, there's a lot, and you will be surprised at some of them. And there's one very interesting, we all laugh at it, med that gets to be used for everything. And then we have a dude from Hazleton, Betty Ford's coming up, and then a person from the Sexual and Gender Medicine Clinic talking about substance use disorder in that population. We're always here for you, as you all know. You know how to get a hold of us by now. Erin, of course, is on. You can see her. Please, if you need any help with anything, questions, please reach out. The online source site, whatever, will have all of the paperwork. We are literally working on it as we speak. Can get into all the echoes, ask questions, check it out. It's actually super cool. It's kind of what we've been discussing for years. How to get a case, you can find the case submission stuff on that website. I'm going to skip through that. The weekly addiction connection, it's not quiet, so just finish.
Okay.
It's water. Anyway, like yesterday was on the final alcohol use disorder medications with the weird ones, but check those out every week. And I had to put this up because you can see behind us, we have fortune cookies. Today is National Fortune Cookie Day, but it's also National Emoji Day. I just didn't think Kurt would approve of that very busy green screen.
Too busy.
So I threw that in there. Sorry, Mark, if you were on from Stratus, I didn't get that approved.
Yeah.
All right, with that, I'm out.
Okay, so what we're going to do is we're going to shift here. You want me to just take?
I'll go sit in here.
Okay. So we have Drew McNamara, who's actually going to give this talk. And this is, we have some cases built into this that I'm going to talk about as we get to them. And she just walked right in front of the camera. And so we'll let Heather, we're going to need to pull up his slides.
They're there.
Oh, okay. So we're just
click.
Oh, there we go. So with no further delay, we're going to let Drew go.
You can use the mouse too.
Okay.
It's easier.
All right. Good afternoon, everybody. It's a real privilege for me to get to talk with you about my paper that I wrote with Dr. Devine last summer. This was a part of our degree that we're earning at Augsburg's PA program in Minneapolis. So I've been enjoying the last month up here with Dr. Bell and Dr. Devine, having a lot of fun. And we'll just kind of jump into this topic. This topic is about co-occurring schizophrenia and substance use disorders. And I chose this topic because at the time I was interested in mental health and still am. And these two gave us an echo through our PA program focused on addiction medicine. So it was kind of the intersection of these two interests that I started talking with Kurt about this.
All right.
So this is just a quick look at some of the words we'll come across in today's topic. If you hear the word co-occurring, it's synonymous with dual diagnosis. We'll talk a little bit about severe and persistent mental illness, kind of re-describe schizophrenia, touch on the criminal justice system as well. So these are our objectives. We'll, like I said, review schizophrenia. We want to understand the degree to which there's more substance use disorders among persons with schizophrenia. We'll talk a little bit about treatments for this co-occurring population. And then we also want to understand the degree to which this co-occurring population is overrepresented in the criminal justice system in the United States. And then Kurt has got some great cases for us. Okay, so topics. We'll talk about the overlap between schizophrenia and substance use disorders, talk about treatments, criminal justice system. All right, so to begin, looking at the prevalence of schizophrenia, it's pretty widely accepted that schizophrenia is represented across the globe with a 0.5 to 1% prevalence rate. In 2016, there was estimated to be about 2.4 million adults in the United States with schizophrenia, which, based on the population at the time, this was about 0.7% of the population. So kind of fits in that range. Pretty significant economic burden with this illness. Okay, and then next, looking at prevalence of substance use disorders. This was a SAMHSA study looking at people 12 years and older. And in 2017, they determined that 7.2% of the population had had a past year substance use disorder. So 15% is actually more of an accurate number for lifetime prevalence of substance use disorders. But this study was showing 7.2 for a past year substance use disorder. And this is just a picture kind of showing the breakdown of different substances at the time that people were using. So alcohol, top of the list. And then you can just kind of glance at those. So we've looked at prevalence of schizophrenia, prevalence of substance use disorders, and then kind of the thrust of this topic is where they overlap. So what is the prevalence of substance use disorders among persons with schizophrenia? If you see PWS throughout this topic, that's what it stands for. One study with 26 articles that ranged from 1990 to 2015 found a pretty broad range of 18.5 to 61.5% prevalence rate, and that excludes nicotine. The reason they exclude nicotine in a lot of these studies is that persons with schizophrenia in many studies approach 90% for nicotine dependence. I have kind of a more conservative number here showing that around more than 70% are nicotine dependent. And kind of an interesting topic in and of itself, just thinking about the cardiovascular risk factors from something like tobacco and smoking and how that might overlap with metabolic side effects from antipsychotic medication, which we'll get to a little bit further into this. I won't spend much time on the last three, but these are just three different studies that kind of point out more specific prevalence rates of substance use disorders among persons with schizophrenia. The bottom one, 20.6%, that was looking at the percent of people who were diagnosed with schizophrenia who went on to develop a substance use disorder. So the bottom number isn't completely synonymous with the top two. Okay, and then another interesting thing to look at is what's the prevalence of this co-occurring population in the criminal justice system. So this was a study done in the criminal justice system in Iowa in 2015. They had a 3% prevalence rate of schizophrenia, which is more than 4.5 times greater than the general population. 26% prevalence rate of substance use disorders, and 28.6% of severe mental illness. That's what SMI stands for. And that's just described as a form of mental illness, oftentimes that has psychosis that's life debilitating, preventing people from functioning in areas of life like work, school, socially. So over a quarter of people in the Iowa criminal justice system had a severe mental illness. And then just comparing that to the general population, we can see big difference there. All right, so what's the etiology of schizophrenia? We don't completely understand it, but it is understood to have both a genetic component and environmental factors. So I'm not going to attempt to take a deep dive on neurotransmitters here. Much of this is over my head.
Yeah, let's not.
It's also over Kurt's head, so unless I move him out of the way, we're not going there.
We'll all be drowning unless you intervene. But basically, we understand that dopamine has a large role in the illness of schizophrenia. And then some of the environmental factors that may enhance the risk include a couple of things I found interesting were winter births and then urban residents. increase the relative risk for
You-
developing this.
You realize Dr. Bell grew up in the city. Okay.
Not in the city, in the suburbs.
Okay.
I was not aware of that. Okay, and then this just further details the genetic component of schizophrenia. I'd bring your attention to the monozygotic twin. So this is saying that if one monozygotic twin develops schizophrenia, the other twin has a 48% chance of developing schizophrenia. Comparing that to a second degree relative of only 3%, it's pretty strongly suggestive that there are some significant genetic factors here. Pathophysiology of schizophrenia, again, we know that there's dopamine dysregulation. The only thing I would touch on here is that we believe the positive symptoms are due to an excessive activation of dopamine receptors. So the positive symptoms in schizophrenia are the hallucinations, people either hearing, seeing, smelling, feeling, even tasting things that don't have a stimulus for them. Most commonly, it's auditory. People hear voices, oftentimes that are derogatory in nature towards the person with the illness. And then the negative symptoms of schizophrenia, we think of these as flat affect, not expressing much emotion, or anhedonia, which is a great fancy term for just having no pleasure, no joy, really no satisfaction at all in life. And these symptoms are believed to be due to low dopamine levels. And we'll come back to some of that with the antipsychotic medications. It's also understood to be developing in utero, and then there are changes in the brain structure. This next slide just shows a picture of a patient with schizophrenia, kind of a dramatic picture. This is the same patient from right to left, just showing different levels in the brain. I just put it in here because it really caught my attention with the decreased real estate in the frontal lobe of the brain here. So I'm sure all patients with schizophrenia do not have this severe of gray matter reduction, but it is something that they see in this illness. Okay, some of the demographics of schizophrenia: mean age of onset between 20 and 35 years of age. These rates are pretty stable across all countries and cultures. And women tend to fall ill with this illness a few years later than men. I won't read all of these statistics below, but this was a study that just was looking at demographics of people with schizophrenia. You can see that this is a really debilitating disease, and I'm sure many of you are familiar with that. But it impacts people socially, interpersonally, affecting long-term relationships like marriage or work relations, needing to be more dependent on family members across the lifetime. And it also increases risk of suicidal ideation and attempts. Okay, before we get too far into schizophrenia, just to point out, schizophrenia is one diagnosis from the DSM-5 among a spectrum. So true schizophrenia, the criteria that are needed for it have to be present for at least 6 months. Comparing that to something like brief psychotic disorder, this might look like schizophrenia, but its duration is less than a month. And then schizophreniform disorder, kind of somewhere in between that 1 month and 6 months. And there's more nuances to that, but I'm not going to go into detail on that. So these are the criteria for a diagnosis of schizophrenia from the DSM. You have to have 2 of the following for at least 1 month. One has to be item 1, 2, or 3. So you have to have hallucinations, delusions, or disorganized speech for at least a month. And then a second criteria as well, which could be something like catatonic behavior. Catatonia is described as, I've heard somebody talk about it as if the patient looks or feels like they're trying to move through jello, or you could move their arm and it would feel as if you're moving a wax statue limb. And that's one side of the pole of catatonia. The other side would be hyperexcitability, agitated, they may be pacing back and forth. So catatonia can actually kind of show up in 2 different ways. And then negative symptoms, which we touched on earlier. Important to this discussion is that the symptoms of schizophrenia are not attributable to a substance. And we're going to talk more about this, but that's an important detail for patients with schizophrenia and in making the diagnosis or managing patients who have it. Other things that can cause psychosis: methamphetamine with acute intoxication, cannabis with acute intoxication. Both of these substances can induce psychosis, maybe visual hallucinations, maybe auditory hallucinations. Interestingly, cannabis-induced psychosis is associated with, oh, sorry about the typo here, an earlier onset of schizophrenia by 3 years. And it's associated with an increased risk of developing schizophrenia in general. So I'm going to hand it over to Kurt. He's going to talk about a case with us.
Yeah, and one of the reasons we kind of throw some of these cases in here is just to show that sometimes when we see patients, and our first thought may be, is this patient, does this patient have schizophrenia? Sometimes there's other things going on. This was actually a case I saw probably 3 years ago in my family practice clinic. He's a 35-year-old guy that I'd known for probably a decade. And I took care of his family and his wife, and he actually presented for an injury and came into the clinic. And just as he was ready to end the visit, he says to me, "Hey, can I just ask you another question?" I said, "Great, yeah, what?" He says, "I've been hearing voices." And I said, "Really?" And he said, "Yeah." I said, "Probably the last month, I'll think that somebody else is in the room. I'll hear somebody talking, and I realize that I'm the only person in the room. And often these voices are saying things to me." And on exam, he was mental status was completely normal. His physical was really normal. He's a big, healthy, big, strapping guy who works construction. And he really didn't have much other history. And I guess, my first thought would be, well, what other questions do we really need to ask this patient? So what other things were really important when I saw him? And if we kind of move to the first thing I really asked him, I said, "Well, geez, is there anybody in your family, that's ever really had any trouble like this that you're aware of? And, anybody that's been diagnosed with schizophrenia or anything like that?" There was nobody in his family at all. And it was interesting. He didn't drink much, but then I asked him about other drugs, and he was not using any methamphetamine, but he'd actually been smoking cannabis since he was 15. He was now 35. So he'd had 20 years of cannabis smoking. And he was well aware that the THC levels of the cannabis was definitely different than it had been when he was younger. And he was smoking mostly before bed, although on the weekends he would often smoke it more recreationally. He felt it helped him sleep. And so really, when we look at a patient like this, the obvious question is, well, how would you manage this patient? Does he need to see the psychiatry people? Are we worried that he's developing schizophrenia and he's going to need antipsychotics? But he really had nothing else but the voices. That's the only thing he really told us about. And so what I did with him is we had a long talk about marijuana. And I just said, "Listen, let's do one simple thing." I said, you have to stop smoking the marijuana. We have to just see if it'll go away, and we'll be very hopeful that it goes away. And it was interesting that over the next 10 days, as he stopped smoking, which was difficult for him, he kind of tapered himself off. The voices became less and less. And I actually saw him back in the clinic 2 weeks later, and it was back pretty much to normal. He hadn't heard a voice in a couple of days. So we had a long talk, and I said, "You're just a guy who's not going to be able to smoke marijuana without doing this. And there's that potential that you have an increased risk of schizophrenia down the road, right? It's a possibility." And so he left, and we'll back up. And one of the things, I actually saw him quite a bit later, and he told me that he tried to restart to see what would happen. And he smoked for about 10 to 14 days, and actually the voices came back. And so then he stopped for good after that point, and to my knowledge, has not had any symptoms since then. So it's really kind of a nice example of sometimes if we get somebody who has a symptom that truly could be early schizophrenia, the marijuana was clearly the thing that I didn't know about him, and when he discontinued that, it just resolved. But again, we may have trouble down the road. We'll see, and he's understanding of that. So you can go on.
Thanks. That's a great example of other things that can cause the development of psychosis and how that's related to schizophrenia. This is just a slide showing a couple tables of other things that can cause psychosis. So to Kurt's point with this patient case example, during the intoxication with certain substances, and then as well on the other side of that, withdrawal from both illicit substances and prescribed substances. Medications can cause some of those. And then we have some medical conditions as well. So psychosis does not always equal schizophrenia or some severe mental illness. Okay, so this is just looking at some of the most commonly used substances by persons with schizophrenia. As a precursor, nicotine by far and above is the most commonly used substance, as we mentioned earlier in the presentation. But cannabis and alcohol, pretty much across the board, are most commonly used. Okay, so we'll talk a little bit more about the overlap between schizophrenia and substance use disorders. What are the outcomes for this unique co-occurring population versus just people with schizophrenia? So this was a study done in Sweden and Finland, and they found that the co-occurring population had worse outcomes. They found that they had worse psychotic symptoms, more medical comorbidities, more suicide. And interestingly, at the bottom here, this was a separate study done on electronic health records, found that the co-occurring population with both schizophrenia and a substance use disorder were almost 20% more likely to die from unnatural causes like car accidents, self-violence and suicide, homicide, compared to people who just have schizophrenia. Why do researchers believe there's such a unique overlap between these two groups of people? Well, some think that the schizophrenia is induced by psychosis. So because there's more people using the substances, or they suggest that, like Kurt's case, cannabis-induced psychosis may go on to develop into schizophrenia. This next study was done on Danish registers, I believe with over 14,000 patients from 1994 to 2016. And I'm going to skip ahead to the next slide because I found this to be really interesting. So I'll draw your attention to the dark line and then the dashed line to begin with. So the dark line is showing cannabis-induced psychosis incidence rates in Denmark from 1994 to 2016. So we see that it increases around 2005, 2006, and then kind of paralleling with that is diagnoses of cannabis use disorder, which would make sense, as well as diagnoses of schizophrenia. Now, I took the liberty of superimposing a separate study, and I'm not trying to say this is a causative thing, but I just wanted to point it out. There was a separate study that studied the THC concentrations in cannabis across all of Europe. So not just in Denmark, they were looking at the average concentration of THC in cannabis throughout all of Europe from 2006 to 2016. And in 2006, when they measured it, their average concentration rate was 13%. And in 2016, the concentration had risen to 30%. So the main takeaway here is this isn't Woodstock weed anymore that we're talking about. The potency has increased quite a bit. And I put this here just because I thought that the timeline was pretty interesting.
To be clear, I'm not old enough to be at Woodstock, so.
You wouldn't know.
Sure. He wasn't cool enough to go to Woodstock.
Okay, so this next slide is another case that Kurt's going to talk with us about.
Yeah, and this is a case that's really about, we're talking about the rise in THC. And one of the interesting things that we've also seen, and I think probably some of you have seen, is that patients are showing up with vapes of marijuana. And this was actually a very interesting case of a guy who occasionally smoked marijuana, and he was 75 years of age. And I would describe this man as a bit eccentric, a bit odd to begin with. He was a very nice man, but just a little bit different. So his nephew and his niece show up from California, and they know that he occasionally smokes smokes a little marijuana. So they bring with them some vapes. And they tell him that these vape cannabis that they're giving him is roughly 80 to 90% THC, and so he should be very careful. Okay. So he starts smoking this, and he began smoking it very much daily. And suddenly I'm getting all kinds of phone calls from his family who have been trying to figure out what's going on. And he's calling them all times of the day or night. He begins dressing like a woman. He is calling the family and telling them that he's horribly wealthy, and he's giving away money. He's giving $100 tips to the guy bringing the pizzas to his house. And so we're getting all kinds of calls about him. And eventually the police go and do a welfare check and bring him to the ER. And in fact, he was clearly delusional. He was having a lot of different problems, and it was really interesting because at the time nobody really understood what he was smoking until later. He was actually taken from the hospital, and he was taken eventually to the psychiatric ward where he went inpatient and started on Zyprexa and some other medications, which really slowly improved his symptoms. He was actually discharged about 10 days later. He was doing pretty well, but on a lot of medications, came back to the clinic. And as most people do, he disliked badly the medications that he was on. And we eventually decided that we would slowly taper him off. He had stopped smoking marijuana. He threw the vapes away. And he, over a period of about 3 months, was tapered off the Zyprexa and was back to his old usual self. And at this point still is. It's probably been about 2 years now and still doing well. So no reoccurrence of that and doing well, but clearly using THC levels that were widely outside of what he was used to. So again, it can make a big difference, and understand that some of the vapes that are around are relatively strong, which that one was. So end of that.
Okay. I'm going to briefly touch on a few studies I came across that had a little bit conflicting results in terms of outcomes for people who are in this co-occurring population. So this next slide, it took me about 25 minutes to understand what was happening in this graph. So I'm not going to try and
explain every little thing.
No. Yeah, I will point out that each colored bar represents a different group that was being studied. So they were studying different cognitive domains, how people functioned with things like abstract thinking, visual memory, language processing. And they studied these cognitive domains in 4 different groups. The blue bar represents our co-occurring group. So it represents people who had a first episode of schizophrenia spectrum disorder and lifetime cannabis use. The red bar represents just schizophrenia, or first episode schizophrenia spectrum disorder. And then the yellow and the purple were the healthy controls. So really the only thing I want to point out here is that the authors were surprised to find that the patients who had first episode schizophrenia spectrum disorder and lifetime cannabis disorder actually did better than the group with just schizophrenia spectrum disorder in these different cognitive domains. Some of them were pretty close, but you can see that the blue bars are not as far away from the mean as the red bars are. And why is that the case? Well, they didn't suggest that smoking cannabis is going to improve your cognitive ability if you have schizophrenia spectrum disorder, but they had a couple ideas. One being that patients who have schizophrenia spectrum disorder and a co-occurring substance use disorder, maybe they already have a higher baseline cognitive ability. And then the other idea being that patients who have schizophrenia without a co-occurring substance use disorder, it's possible that the development of their psychiatric illness may have a harsher etiology or a harsher disease course being purely genetic or other environmental factors that don't have anything to do with the substances. So just wanted to include that because I thought it was interesting. I took a look at a few studies examining imaging studies of patients with schizophrenia and substance use disorders, and pretty much across the board, they found decreased gray matter in various areas of the brain. We looked at that image earlier, which was pretty dramatic. This study did find that the patients with co-occurring substance use disorders and schizophrenia spectrum disorder were actually less cognitively and emotionally impaired. This is a different study than the one with the colored bars. And I'm going to skip ahead to the next one here. So next we're going to talk about evidence-based treatments specifically for this co-occurring population. So what do all antipsychotic medications do? Well, a quick summary is that they all reduce dopamine transmission, but not all antipsychotics are created equally. And many of you are probably familiar with the different generations. So first generation antipsychotics more strongly antagonize the D2 dopamine receptors. And this picture just shows a couple of neural circuits in the brain where dopamine is transmitted. So first generation antipsychotics like haloperidol would antagonize strongly at these receptors. And then second generation antipsychotics, they do antagonize dopamine, but they also have a high affinity and they antagonize serotonin 2A receptors. They also agonize other serotonin receptors. So a little bit complex and kind of like the new neurotransmitters. I didn't do a deep dive on all the subtleties of antipsychotics, but just wanted to introduce us or do a quick review on how antipsychotic medications work. If you're looking for some material to read before bed, I would strongly draw your attention to this table.
Yeah, memorize this. Try.
If you have a hard time falling asleep. I came across this in PA school in our psych unit. And really the main takeaway here is just looking at the first generation antipsychotics down here. Lots of more plus signs underneath the extrapyramidal side effects. So things like tardive dyskinesia, Parkinsonism. A patient might look like they have Parkinson disease, have movements, like a masked face due to the side effects from some of these older antipsychotic medications. And then pointing out with the newer second generation antipsychotics here, we have more plus signs underneath the metabolic side effects. So things like weight gain, glucose abnormalities, and hyperlipidemia. Okay, so big picture with different results on antipsychotics that have been studied in this co-occurring population. There isn't any great evidence that says this antipsychotic is the best one for all patients in this co-occurring population. It just doesn't work that way. They found that there's no superiority of any single antipsychotic across multiple outcome domains. One thing they did find was that clozapine and olanzapine, which are both second generation antipsychotics, were superior to others in terms of all-cause discontinuation of antipsychotic medication. Now that's interesting in this population because one of the big barriers to long-term success or positive outcomes has to do with medication adherence. And we'll talk about some of the barriers to medication adherence. So why would patients not adhere to these medications? Well, if you recall the table from 2 slides ago, there's quite a few side effects. Certain patients are going to tolerate side effects better than others. It also may depend on what are the patient's comorbidities when they're started on antipsychotics. So if there's a patient who's already obese and they're started on one of these antipsychotics that increases weight gain, it could cause more problems for them. So the side effect profile is certainly one of the things that might cause non-adherence, as well as use of substances, the disease process of schizophrenia itself, just having disorganized thoughts could lead to missed doses, and then a lot of lacking of social and financial resources in this population. So what's one way that people try to improve medication adherence in this co-occurring population? Well, it's the long-acting injectable antipsychotics. So this was a multi-center observational study, not a huge sample size, but it looked at 40 patients in this co-occurring population, and they gave them long-acting injectable Abilify for 6 months, 400 mgs every 4 weeks. And interestingly, at the end of that time, they found that 20% of the patients who were in this co-occurring population were able to stop using a substance. One question I would offer is, was it the antipsychotic that caused them to stop using the substance, or was it just kind of the stabilizing of their psychotic symptoms and organizing their thoughts in a way that made it easier for them to stop using substances? This was another study looking at long-acting injectables. It was a 3-year prospective and retrospective study looking at the same 237 patients who'd been on oral antipsychotics for 3 years, and then these same patients once they were started on long-acting injectables. They found that once they were started on the long-acting injectables, they had nearly a 10% lower relapse rate of using substances, over 200 days of increased relapse-free survival time, and almost 300 days more of hospitalization-free survival time. So this graph just shows their study, the orange line being the group with long-acting injectables, the blue line being the group with oral antipsychotics. So it's the same people. The blue line was 3 years before they started the LAIs when they were on oral antipsychotics, and this is showing the proportion of them without relapse. And you can just see that there's a greater proportion of patients on the LAIs who were relapse-free. And then over here as well, a greater proportion of patients when they were on the LAIs were without hospitalization compared to the oral antipsychotics. Okay, so what are some of the barriers to use of long-acting injectable antipsychotics? Before I talk about this qualitative study, I didn't include any information on this, but I think it'd be interesting to look more into. There's a financial disparity between the cost of LAIs and oral antipsychotics, and especially in the United States, there's insurance coverage issues where these medications are not accessible to all. So this study is a 2-part qualitative study that was asking both patients and physicians, in this case psychiatrists, what their perspectives were on long-acting injectables. And I'll draw your attention to these couple of comments here to begin with. So this study was asking patients who did have previous experience with long-acting injectables, as well as patients who did not have experience with long-acting injectables. So this individual noted that their perceived advantage of long-acting injectables were that you do not ever have to take pills every day. Injectables let me be able to forget that I'm on medication, and it lets me focus on my recovery. I don't have the option to not take my medication because it's always in my bloodstream. And then their perceived disadvantage is that I have to go to the clinic every 2 weeks to get the injection. When I want to travel somewhere, I have to make arrangements to take the medication with me and find a clinic to get it injected at. So those are comments from somebody who's had LAIs before. And then comparing that with somebody who's not had LAIs before, the perceived advantage is, well, they last longer. And then a different person said, the perception is that it is mostly for non-compliant people, therefore it's like a punishment. So there's a bit of a punitive idea with some of these long-acting injectables. And we see some of that portrayed in movies, one being One Flew Over the Cuckoo's Nest is kind of a famous one where the main character is pinned down and given a Haldol injection, and it can be pretty dramatic. So there certainly is some associations with these long-acting injectables. So part 2 of this study looked at psychiatrist perspectives. So this was asking psychiatrists how often they prescribe long-acting injectables and orals. So just a quick look here. 12 of the psychiatrists said they rarely prescribed long-acting injectables, comparing that to those who prescribed oral antipsychotics. 16 said most or all of the time. So pretty big difference here. And this was just from a small sample size of psychiatrists in 4 different provinces in Canada. So this isn't necessarily descriptive of all psychiatrists everywhere. I just wanted to include it. Okay, I'm going to actually skip over a couple of these slides here so we can keep moving, keeping an eye on time. So there's the pharmacotherapy, and then there's the non-pharmacological interventions for this co-occurring population. Very important to consider that this demographic requires more than just medication management. This was a study done looking at something they called a care management bridging strategy. And they looked at 1,243 Medicaid enrolled adults in Pennsylvania who had been readmitted for a psychiatric illness, a substance use disorder, or a co-occurring or dual diagnosis disorder. So not the exact fit. All of the patients didn't have schizophrenia and a substance use disorder, but I thought it was informative. So what they found was that the group who received the intervention, which they defined as a 15 to 30-minute face-to-face on-site conversation, talking about things like, do you understand why you were readmitted to the hospital? Do you have a plan going forward out of the hospital today? Do you have the phone numbers, or basically just making sure they're connected and they understand what the next steps are? And this was compared to the usual care, which was just defined as making the referrals to the outpatient treatment centers that these patients might be going to. And they found that there was a decrease by 3.5% of, excuse me, I lost my spot. They found that patients had an increased rate of following up with the services and a decreased rate of being readmitted to the hospital with a substance use disorder cause within the next month.
I think that proves again that talking to people helps.
Absolutely.
Did they say anything different with like telehealth versus in person? I mean, that would be my question, and it would be more of a follow-up thing now versus when that study was done.
Yeah.
You know, like, does psych patients do as well telehealth versus not?
Yeah, I think that'd be an excellent study. Okay, so we're getting to part 3, the final part of my presentation today, and this is the criminal justice system. And we want to talk specifically about how this co-occurring population is overrepresented in the criminal justice system, and I'll speak just to the United States. So to begin with, the US has the highest incarceration rate in the world. And this is taken from 2021 data. Oh, you're fine. And I just want to draw your attention. I underlined both the incarceration rate and then the number of people incarcerated in the US. So the incarceration rate is 629 persons per 100,000 people. So, you know, you can't get any higher than that right now. I think it's interesting to just point out some of the other countries on the list. A lot of these countries have had pretty significant civil strife and other issues that have maybe hindered their progress or development as nations. So I point this out here. The red line is showing the average incarceration rate of all countries in the world, which is 165 people per 100,000. And then I hover over the United States incarceration rate, which is 629. And I believe China is second to the United States. Okay, so what does this have to do with mental illness and substance use disorders? In 2017, there were 10 times as many people in jails and prisons with severe mental illness than there were in state mental hospitals. So how the heck did we get here where the majority of our individuals with severe mental illness, well, maybe not the majority, but where they're overrepresented in jails and prisons than they are in other areas? So this is a historical glimpse at deinstitutionalization. I think this could be an entire talk in and of itself. And I didn't include this in my research paper. This kind of more came out as I was getting ready with Kurt and Heather to talk about this. But I just wanted to offer this as a kind of where we've come from and how we've gotten to where we are. In the 1950s, there was over 500,000 people in United States psychiatric hospitals. And then below that is just a reference to what the population was at the time in the country. So in the late 50s, mental health reforms took place. And the idea was to move people from psychiatric hospitals into a community care model, which certainly sounds great. And I believe that the intention was probably good at the time. some of the reasons why these reforms took place were there was a belief that these hospitals were cruel and inhumane. And certainly if we look at some of the history in psychiatry, not just in the United States, but across the whole world, there certainly are some cruel and inhumane things that have happened to patients with mental illness. But there was also the belief that these antipsychotics that were being introduced were a cure, almost as if we're curing mental illness, we're curing these psychotic conditions. People no longer need the level of care that they once had in these psychiatric hospitals. And then lastly, the government also saw an opportunity for massive financial savings in closing down many of these psychiatric hospitals. So fast forwarding to the end of the 90s, we saw a drop of over 450,000 people from US psychiatric hospitals. So at the end of the 90s, there's only 38,000 people, yet the population of our country has almost doubled. So what's my point here? In 2010, it was estimated that 16% of people in jails and prisons had a severe mental illness. And certainly the 378,000 people that are in jails and prisons with severe mental illness are not all of the same people as back in the 1950s. Lives have been lived, others have been born and developed severe mental illness. But I just point that out to say, in some ways, we have translocated our people with severe mental illness from psychiatric hospitals to jails and prisons. This was a study that looked at incarcerated adults in Massachusetts prisons, and it used ACE scores, or adverse childhood experiences. It defined a high ACE score as being greater than or equal to 4, and a low ACE score as less than 4. It's a small sample size, but I just thought it was interesting, and I wanted to highlight the role that adverse childhood experiences play in the development of both mental illness and substance use disorders. They found that the 19 participants in the high ACE group, 94% had a mental health diagnosis, 73% had substance use disorder diagnoses, quite a bit higher than the group with lower ACE scores. All right, and I'm getting to the end of part 3 here. Lastly, I wanted to tell you a little bit about an expert interview I conducted with the Behavioral Health Services Director, Angie Newstrom, and she's had experience in jails and prisons. So I asked her a few questions about this co-occurring population.
Did you tell her that we're doing this today so
No,
she could have been on?
So I asked her first, what are some of the unique complications among this dual diagnosis patient population in the criminal justice system? And we'll start there. She had some really insightful things to share with me. She talked about this revolving door reality where people show up in prison or jail, they're having psychotic symptoms. Maybe they do have schizophrenia and they're adequately managed on an antipsychotic medication. They return to the community. Maybe they go off of their medication and they return to jail and prison many times for no criminal offense at all. Sometimes I'm sure that there's a criminal offense, but many times it's not because they've committed a crime. She also said that there's a lack of prior medical records in the jails and prisons. And I thought this was an interesting point because say you have a patient who shows up and they're having auditory hallucinations, and you think, wow, we should probably manage this patient with antipsychotic medications. Well, what if similar to Kurt's cases that have been shared throughout this presentation, this is a substance-induced psychosis, and it might clear if we give them enough time. Maybe we give them a couple weeks, a month, and the symptoms go away. We could be doing harm to people by starting them on antipsychotic medications when they may not, in fact, need them. And then lastly, she talked about the difficulty in jails and prisons to prove that a patient is unable to care for themselves or they're a threat to themselves or other people. She said in environments like institutions like jails or prisons where people have a roof over their head, even though they're confined there, if they have shelter, meals, a bed, it can be difficult to prove without a doubt that they are unable to care for themselves at times. And she said what this leads to is almost needing to let patients with severe mental illness deteriorate to an uncomfortable level, she said, before you can intervene and actually give a medication that a patient may very badly need in order to give them the help that their disease requires. So I thought that was kind of an insightful thing. Then I asked her, how do long-acting injectables come into play? She said, generally, people on long-acting injectables, if they receive them prior to incarceration, will continue to get them. She said she thinks they tend to do better anecdotally, fewer opportunities to miss or skip doses. And then she also said, importantly, there's not as much of a need to convince patients to take it. And I don't have a lot of personal experience working with patients who take antipsychotics or having observed this, but I've heard that it can be difficult at times where patients may not want to take this medicine. Okay, and then lastly, I asked what barriers interfere with this dual diagnosis population from doing well once they are released from prison or jail. She basically just said lack across the board. She said they lack the necessary supportive social networks. I pointed out earlier on a slide of demographics, many of these patients may not have a partner. They may still be dependent on parents. They may not have the social structure required for them to do well. They may lack stable housing. She said, especially in rural areas, we lack psychiatric hospital beds. Patients can spend hours to days waiting for an open bed in emergency departments. And then community health centers and psychiatrists, she also mentioned, we need more of for this population. So that is our presentation for you today about this population with co-occurring schizophrenia and substance use disorders. Thanks so much for listening. It's a real privilege for me to get to do this with Doctors Devine and Bell. It's been a lot of fun.
Looks like
Did you literally just call me that?
I think we do have some
Let's take down the
questions.
slide, Kurt.
Okay, let's switch spots.
But-
We'll go to the questions.
All right. No, you can stay there.
Okay.
Yep.
He just can't run electronics. Okay, so how does that increase the mortality for co-occurring? So I might have missed the location that this came through. So, oh man, compared to non-schizophrenic patients with and without. So mortality differences with patients with and without substance use disorders who have the diagnosis of schizophrenia, I think is what the question is getting at, Greg.
Okay, that's a great question. From what I came across, I saw that the patients with co-occurring schizophrenia and substance use disorder, the one study I saw on this noted that they had a 2 times mortality rate compared to the group with just schizophrenia spectrum disorders without a substance use disorder. So more, and the means by which they die are typically more accidental, violent, suicidal.
It's interesting because we always talk with like the state on like overdoses, for instance, and was it an intentional overdose or was it an accidental overdose? And I think throwing on something like schizophrenia where you already have a higher, both suicidal thoughts, but also, sometimes those negative symptoms of the voice is telling you to do bad things. So to me, that's just in my brain anecdotally, but.
Yeah.
Okay, from a personal experience, believe that a family member or close friend needs to be included in the plan. It wasn't specifically, you mentioned the plan. Did you see anything specifically though in it? And if you didn't, because it wasn't the focus of this, what percentage of people even have that person part of their plan? Or are they so isolated or so, did you see much in there?
I didn't specifically come across that. Anecdotally, I have a family member, an in-law with schizophrenia, and he's had stable parents in his whole life. And he hasn't been faced with a lot of the hardships that I think patients who don't have stable social networks have to face. So sorry, I don't have much to speak to that about studies.
All right. for full disclosure, Audrey is a nurse in a jail.
Okay.
So I could probably name all the people on here who have worked in jail. So she knows Angie. It's also really hard to get these patients to actually take their medications while incarcerated. So you talked about that. And I know Angie mentioned there's less reluctance in some aspects, but I think just anecdotally, sometimes they just don't want to. And I know we dealt with a case in one of the county jails in the network where the patient didn't want to take them. And then it like escalated to, more delusions and more psychosis. And what do? Because you can't force them. You can't like tie a person down and you can't do restraint by drug.
Yeah.
So I think, and I'm sure Audrey, you've seen that.
I think that's a great point just to the dilemma or the difficulty and why this population they have a lot of complex difficulties in their management.
And I think even more than just mental health in general, easy mental health, anxiety, depression. Not that I'm just kind of saying like on the spectrum of mental health, maybe those would be considered easier. I'm not trying to put my foot in my mouth. I'm just putting it on the spectrum. That's already so like a stigmatized group and so difficult in certain aspects. And then you take another huge stigmatized group with use disorders and you put them in the same person.
Yeah.
Yeah.
A lot of stigma there.
This is huge. Okay, Tim, City of Cure versus the City of Care. Transplant Center resides in the City of Cure category. Mental illness resides in the City of Care. Long-term lifetime care that society is less likely to want to pay for. And that's huge, is the funding of all of those things. Okay, Brittany, Brittany, our new nurse in addiction, but came from a jail. So not from a jail patient, she works in a jail as well. Patient had been incarcerated for 8 months, frequent refusal of oral meds, county approved injectables, finally huge change.
Wow.
So, and I think that's what we've seen in different facilities too. Yeah, there you go. And Aaron, of course, jails. So I did have one question. And when you were talking about the long acting injectables, and just the difference in like psychiatry and what they said, did you see anything about like the long acting injectable antipsychotic medications also with like an injectable stuff like Vivitrol or Sublocade?
No, I didn't come across that, but that's a great question in terms of, could we do like a combo therapy or do they interact at all?
That was, because if you do have that co-occurring and you already have difficulty with taking medications, I was thinking, God, would they negatively interact or would that be?
Yeah, I'm sure there's studies out there. I didn't personally review them. I think that's a great question though.
Is the long-acting injectable available without a prior auth or it's an insurance barrier? Do we have a pharmacist on here? We have a couple of pharmacists. I would guess it's a prior auth issue. Yeah. Do any of the pharmacists on here, I don't want to call you out, that would be rude, have any thoughts as to using two different long-actings or injectables, I should say, or anecdotally, or any like papers that you've seen?
Hi, this is Paul Shiras. I'm a pharmacist at St. Cloud Hospital. I don't have any information. I'm actually behavioral health and opioid use disorder is not my strong suit. That's why I'm here to learn. But I've not seen anything about sort of using them together. I don't have any drug interactions that come to the top of my mind off of that. That would prohibit the combination. We use the orals and can use the orals and the IV Vivitrol together. There isn't any contraindication there. So I'm assuming you could use both long acting. But, in terms of the insurance barriers, it really depends on insurance. There are a lot of programs of getting people onto the long acting ones, coupons and different things. And so, I think some people are able to get on it without an extensive prior authorization, and some people have better luck with insurance. But yeah.
Thanks, Paul. And there was that comment just made along the lines of some of that is, especially if we're talking criminal justice and the recidivism costs versus the county just paying for that injectable. That's a lot of argument about MAT and the same thing. Multiple, yeah, easier to get it approved if they've had all their oral antipsychotics documented not being effective. This is huge. I mean, this is a huge topic, and I was surprised when Kurt mentioned you did your paper on this, like of all different things. Like this was cool. I'm glad you were able to do this and willing. But
Absolutely. Well, thank you so much for letting me talk about it here. And it largely had to do with our conversation, advisor meetings. I got to give Kurt some credit, but also thank you for doing the ECHO with Augsburg. I think that was kind of initial exposure to, for a lot of us, to what addiction medicine is.
yeah, this is great. So if anybody has any further questions, we're going to get the sources on some of that criminal justice thing, because there's so many of us that are like, let's do some more research and a whole topic on that. So, all right, there's the certification survey thingy. If y'all could fill that out. Next week, Kurt's going to come back and talk about the medications for alcohol use disorder treatment, both on, approval lists and, not anecdotal ones, some of them. And so it'll be good. Thank you, everybody.